This week on the BackTable podcast.
And we all know that it's going to ultimately kill 95% of patients who develop these cancers. That's a huge percentage, and it's an incredibly morbid death from ovarian cancer. Not to say that it's not from other cancers, like you said, but it is just so much harder to find. And I think that's why our threshold, like we said, the 5%, that's why our threshold is so low for doing a risk-reducing surgery. And fortunately, unlike, a prophylactic mastectomy, at least, you have some small scars from it, but you don't have, it's not as huge a deal with like reconstruction and things like that. There are like we discussed, implications for menopause and other things with taking out the ovaries, but it seems like an easier decision, I think, sometimes than maybe mastectomy.
Welcome to BackTable. We are guest hosts with you guys today. We're both GYN oncologists. My name is Mona Guo, GYN oncologist at the University of Southern California, where I did my training fellowship, where Marcia Ciccone was one of my amazing attendings.
I'm Marcia Ciccone. I also am an attending GYN oncologist at the University of Southern California, and just a couple years above Dr. Guo. Both of us did our fellowship and now work at USC. I did kind of all of my training at USC, so I did medical school and undergrad, and then also residency and fellowship here.
Lifer,
I know.
Trojan lifer.
It's like good, but also like, wow, I just can't leave or something. I don't know.
We don't want you to leave. Please don't leave.
I'm here.
Yeah.
So I think today we were going to talk to you guys about hereditary gynecologic cancer syndromes and kind of how to approach that. And I guess basically our approach to that and ways in which we can share that and help prevent disease in the future. Because if we can prevent disease, that's ultimately the best way to go about medicine.
Yeah, we were trying to decide what to start with for this little mini-series on GYN oncology, and thought that this was a good place to start, relevant for medical oncologists, for generalists, OBGYNs. And we both have some experience in the area. I mean, Marcy, you are the co-director, right, of our genetics program at USC, and you've done some extra training in the area.
Yeah, currently I serve as the co-director of our genetics program. And then after fellowship, I did some additional training. The City of Hope has an intensive training in cancer genetics. And so I took some extra time and did that course and got certified in that area. And so I have a little additional training in that area. And I know you specifically also work in our Lynch Cancer Center and Clinic, which is a actually funded clinic in support of genetic cancer syndromes, where we can coordinate care for our patients at USC amongst multiple providers. So you in clinical practice see a lot of these patients.
Yeah, I wouldn't say you had just a little training. I mean, we all know that we don't get much training at all in genetics through like medical school or residency. It's kind of just put on the wayside.
We really don't. And so I feel like it is something that is there's less knowledge about it for that reason. And it does have, as we learn more and more about it, we learn that it is applicable more and more to many, many patients. And there's actually a lot that we can do to prevent these diseases and to help keep people healthy. And if we paid a little bit more attention to that, then it's something that we could all benefit from.
Yeah. I mean, you and I have both had patients who have come in with late stage cancer that could have totally been prevented if someone had just did a little bit of a family history or thought, hey, she had breast cancer in her 30s. Mm-hmm. Why hasn't she been tested? And now she's in her 60s with ovarian cancer. And it's really sad to have to talk to someone, not just about their cancer, but then about, hey, this could have been prevented or at least detected maybe a little bit earlier.
I mean, I've also had patients who actually have been diagnosed with mutations and then were never told or were never counseled correctly and didn't know that there were additional screening or additional procedures that they could have to help very simply prevent certain cancers that then later developed. So I think as a general place of knowledge, I think it's important for doctors to know.
So, I mean, I guess starting from there, when do you think about a genetic syndrome? Again, if a patient comes to see you, I mean, that question's really broad, right? Like, if a patient comes to see you, what are some red flags in their history, their family history that should really make you think, hey, this patient should be sent to either a genetic counselor or to get tested?
Yeah, I mean, I think this is important because we all kind of collect this data, especially as part of our routine history and physical. You collect a family history from your patients. So ideally, you not only just kind of look at what's already in the chart, because all of our charting systems have, what their family history that your nurses have entered. But I do think it is important to take a very detailed family history and to ask your patients not only about their personal history of cancer, but to be a little bit more in depth than just saying, hey, does anybody in your family have cancer? Well, I always ask them specifically, any uterine cancer, ovarian cancer, breast cancer, GI cancer. And then I also ask about like aunts, uncles, grandparents, because people kind of tend to forget about that. When you ask them about their family history, they tend to think, oh, my brother had this or my dad had this, but they don't really think beyond first degree relatives a lot of times. And so I think it is important to specifically ask that. And then, one of the other things that I think, you can go through the guidelines and, you can look these things up, of course, about when you should refer people for genetic counseling or what people would qualify for genetic counseling or what specific history items would qualify them. And there's a whole, laundry list of things that you could come up with. But I think, when it comes to just practical application of this and you're sitting in clinic and you're taking history and you want certain things that will trigger you or certain things that will say, hey, this person, should be seen. I think there are a few things that make it easier. And so one of the things you think of is people who are diagnosed with breast cancer, specifically in ovarian cancer, because they tend to be much more genetically linked. And then it's interesting, and these are kind of the easy things to think of, but if you have anybody in your family, whether it's first, second, or third degree relatives who have had ovarian cancer, that automatically qualifies you for genetic testing. In addition to, of course, the fact if you have had ovarian cancer yourself, because we know that about 30% of patients with ovarian cancer can actually have identifiable genetic mutations if you were to do the testing. And then same thing with breast cancer. Of course, breast cancer is a very common cancer and it's not always genetic. But because there is a link to BRCA and a variety of other mutations, if anybody has a family history of breast cancer and that person who had the cancer was 50 years of age or under at the time of diagnosis, then that is suspicious enough to warrant genetic testing. So I think those are two very salient things that are easy to think of when you're taking a family history.
I think it took me a while to realize that it was one person is all you need. You don't need this family history of multiple aunts and, your grandma and your aunt and someone else who has ovarian cancer. Or I think we were talking about this earlier, any metastatic prostate cancer.
Yeah, that too.
Right? Any within this 3 degrees of separation, right? Mm-hmm. Relatives, 3 degrees.
3 degrees of separation, yeah.
Yeah, that you don't need, you don't need much to qualify, which was news to me, I think, after I started really practicing.
I mean, I think, of course, beyond breast and ovarian cancer, right, there's also things like Lynch syndrome tends to be something that's very common, or that at least we see very commonly. Maybe we have a little bit of a bias, of a prevalence bias. But when you start seeing a lot of GI cancers, stomach cancers especially, tends to be a lot of hereditary stomach cancer. So that's always kind of brings up a red flag in my head. But things that a lot of family history where there's endometrial cancer combined with colon cancer or GI cancers, and then even renal cancer, so renal or urinary cancers, kind of should start bringing up Lynch syndrome in your head.
There are those standardized scoring systems, right?
Yes.
I know that some of them are super long. I mean, we have Tyrer-Cuzick, and then some other ones that I've seen our genetic counselors use that requires, it's just, they have so many data points in them that oftentimes I feel like I can't take that time in a 15-minute encounter to fill these things out for them. Then the patients would come in saying hey, I found this online and I filled it out and it seems like this is what I might have an elevated risk. Do you think, especially since you did that program, do you think that we as OB or OBGYNs, as GYN oncologists, as medical oncologists, we should just be ordering those tests? Or is it better to send patients to a genetic counselor since you got the extra training?
I think that's a good question. So one of the things, of course, is a heavily biased because the training was from a lot of genetic counselors. So, and it was done by our genetic counselors. And I ultimately agree with them that the best case scenario is when patients do get counseling from genetic counselors in addition to the testing. Because I think first and foremost, they talk about doing pre-testing counseling and then post-testing counseling. And one of the reasons why pre-testing counseling is important is because patients need to know what they're getting themselves into when they order these tests. They may have a lot of questions about what are the implications of the results. Like, is my insurance going to be affected? Is somebody going to tell me I have a pre-existing condition? If I take this test and something comes out positive, how is that going to affect how I pay for insurance in the future? Is that going to raise my premiums? And hopefully with the laws of today, that is not something that people have to worry about. But there actually are laws in place specifically for genetic testing and for genetic testing results to protect people against that. Another question that might come up is because we don't know everything about genetic testing, right? So it's important to counsel the patient that whether the test is positive or whether the test is negative, it doesn't mean that there's no genetic risk just because your testing is negative, because we don't know all the genes that cause cancer and we can't test for all of the genes that cause cancer. So I think there's some degree of counseling that is important to share that with the patient. I think another thing is telling them, hey, this result might make you feel a certain way, or it might make you feel anxious. So there's some patients that might be more anxious because something's positive, whereas some people might feel better because they have a better handle on what's going on. And so every patient's going to be a little bit different in that regard. And then in terms of the result, it's important to understand too that there's not always a positive result and a negative result. Sometimes there's something in between, because there can be so many genetic changes. Not all of them cause dysfunction in proteins and dysfunction in the actual cancer-causing genes. Some of them are just simple misspellings that don't cause a problem. And so sometimes that you'll get what comes back as a variant of uncertain significance. And it's important to figure out how to counsel the patient about that. Yeah, because the patient looks at this thing that's showing up on their test result and they're like, this is abnormal, right?
I look at that thing and I'm like, what do I do with it?
Yeah, me too. Especially when I get a VUS and it lines up with the actual disease that they have. Yeah. I'm like, is that really a variant? Like, are we sure that doesn't cause disease? And then it's very tempting to act on it, even though the guidelines are like, you shouldn't do anything about a variant. Because the guidelines state that 90% of them are going to get reclassified as nothing. And then 10% are going to get reclassified as something. But it's also important that if a patient has a variant, that they continue following up. Because eventually, once more data comes in, that should get reclassified. And if it does get reclassified as something concerning, then maybe there is something that they need to worry about. So I think that's something that tends to get forgotten, and that I think genetic counselors do a much better job at counseling on those things. And then, of course, when the test result comes in and you actually have a mutation, getting counseling or getting referrals for all the proper screening is really nice when you have a genetic counselor that knows about all these mutations. And I'll confess that even after doing that class, I don't do it frequently enough to be able to counsel patients on things that are not really in my field, like things that apply to like leukemia or urinary cancers. I'm just not as comfortable with that. And so I think having a genetic counselor talk about all those things is important. The caveat being that not everybody is going to have access to a genetic counselor, and should you not do the testing if the patient doesn't have access to a genetic counselor? Which I think if you don't have access, yeah.
Don't a lot of these commercial tests, they are supposed to be connected or have a genetic counselor that's looped in with the test?
I think so. I think they're working on remote platforms. And I think maybe since telehealth has progressed with COVID, that maybe that has advanced a little bit more. When I did my training, it was still pre-COVID. And so there may be more resources now than there were when we first were going over all of those things.
Yeah. I think just having that like separate, another touch point, someone else to then go over this with you. Because I get referrals, and I'm sure you do too, from patients who have had genetic tests done in the community, whether it's their like PCP or their generalist just sent it because of family history, which is great if you send it. But if you don't really follow up and do the things, if it comes back positive, and make sure that the patient follows up, like what is really the point of knowing? Yeah. But I mean, I'm fortunate, and we are fortunate, I think, at USC to have something like Lynn Cohen Foundation, or the Lynn Cohen Clinic. It's a foundation that was started by this wonderful woman whose mom had gone through ovarian cancer, and they did not have any, like they had no BRCA, no identified genetic marker, at least at the time. I don't know if anything else has changed. And so they funded both here as well as over on the East Coast, this prevention clinic for patients with high-risk breast and ovarian cancer. That is a really great amalgamation of having us, having medical oncology, and having genetics. Our genetic counselors kind of get together after every clinic session to go over our patients, make sure we're not missing out on any necessary referrals, to discuss the most hot topics in hereditary cancers at the time, which right now it seems to be a lot to do with contraception and the risks of breast cancer, which is I think a whole separate episode that we can talk about.
Definitely.
But they all come to me already having had genetic counseling and already having had a genetic counselor that has listed, these are the screening things you should get for not just GYN, but for every other organ system that they might need. And that when I see them, they've already had that counseling, and it makes my job a lot easier. But we're being at a large academic center, it's one benefit to have that. But I do think that getting your care or referring someone to a center like this is ultimately good for the patient because they don't have as much care fragmentation. And at least here they can get their screening, like their ultrasound for the breast, as well as their MRIs or their mammograms on usually the same day as when they come and see their breast providers.
I look, that's a huge benefit to patients to kind of get everything streamlined. It's so hard to organize healthcare, and especially in our era where everything's so fragmented, you have to make all these phone calls. It's so hard for me. I don't know how the average person manages to do that. I'd rather just go through the back channels and figure out how to get things figured out. But I think that's a huge resource and overcomes what can be a huge barrier to getting care.
Totally. That's where hopefully AI can help us with that.
Yeah, seriously.
Right.
Weird question, but what would you do if you were practicing in a more remote setting and, you were coming across these patients? Because I'm sure we probably have some people that are in that situation. How do you think you would handle genetic testing and genetic counseling in that scenario?
I think I would text one of my genetic counselors.
Yeah. I think I'd phone a friend.
Call a friend. I mean, going back it is fairly easy to order genetic testing now. So I think if I were to not have a genetic counselor easily accessible, or for some reason someone's insurance doesn't allow them to see one, or they don't have insurance, if there's a way to order it, there are a lot of, I think, financial assistance with these genetic tests as well, because ultimately it's going to decrease healthcare costs to act on something earlier than to wait for a cancer to develop.
And I do think that if you meet the qualifications for testing, then insurance does cover it. But I think it probably needs to be coded correctly so that, so that happens.
So if it is that easy, it is easy to order these tests. So I think I would order them. Some of these tests actually they have mobile phlebotomy, which is pretty great, that the company will just help set that up to go to your patient to collect whether it's blood or saliva and I think that really decreases that barrier of needing someone to come in to get that done or to schedule around it. But then to make sure that you're following up, that whether you're going to get these results or is it the patient that's going to get these results, is there some portal they have to go on to, and to not just order it and forget it and say you've done it or say I've done it.
Yeah, that is not the end of the story.
Yeah. If it does come back positive, then trying to figure out what I can do and what are the possible screening things that we can do. The NCCN has great guidelines for this. So does ACOG, at least for gynecologic cancers, for what screening should be done. Also what the approved or beneficial risk reduction strategies are.
Yeah.
Which, depending on the cancer, there's a bunch that we can talk about. But I think so from screening.
Yeah. So maybe we should get into that. Let's start with screening. Let's say, what do you actually do? You get a positive result on one of these tests.
Yeah.
And of course, it's going to depend on what test that is. But let's say, somebody walks in to you in Lincoln and they have a positive test result for BRCA. Or let's say it's not even in Lincoln. It's not a patient who has not had genetic counseling. She just walks in. She's like, I'm coming to see you because I am, let's go with BRCA1. I'm BRCA1 positive. And of course, age matters too, right? So let's say she's 30, 35 years old. What do you say to her? What should I do with myself? How should I be worried about this?
I always start with, what do you know? Like, you got this test, what have you heard? And has anyone else talked to you about it? Sometimes patients are coming in because they have family members who have been diagnosed, and then they go and get tested themselves. And so they've heard things as well. Assuming this is, I guess we can go like bare bones, that this is a 35-year-old who decided to do 23andMe before that they went out of business and comes in with this result. Again, I think, what do you know? Because BRCA, thankfully, in the media has gotten more attention, and people do know something about it with, Angelina Jolie and her doing her risk-reducing surgeries. But asking them what they know, and then I start usually with doing a little anatomy lesson, just so we know exactly what we're talking about. And I think it helps our patients just understand, right? Our uterus, ovaries, they're different things. Your cervix, they're all different things. And where they are, that we can't just like do a pap smear and be able to pick up on what's going on with the ovaries.
Yeah, everybody always asks me that. Well, how come this didn't show up on my pap smear? And you're like, that's not what pap smear is for. Yeah.
Exactly.
There's a lot of misconceptions.
And then I usually just start by saying BRCA1, which you have, it does increase your risk of breast and ovarian cancer, as well as some other cancers. We all, as women, have a baseline risk of both breast as well as ovarian cancer. So everyone has a risk of developing cancer in any organ. But when you have these mutations, it can increase that risk pretty substantially. So for breast cancer, I think it's up to 70% risk for BRCA1. And then for ovarian cancer, it's like 40% or so. And that's a lifetime risk. It's not that tomorrow you're going to get breast cancer. It's that, up until, was it age 70, I think?
I believe so. I think that's what they consider lifetime.
That you have that increased risk. Answer any questions that they might have. And then this young lady is 35.
35.
Well,
right that nice cutoff.
Yeah, exactly. You say that because 35 to 40 is when we do recommend ovarian risk-reducing surgery for decreasing that ovarian cancer risk. BRCA1 is the earliest of all of the genetic syndromes that we have for doing this, right? I believe. And by taking out the ovaries, it does decrease your chance of ovarian cancer by 90+%, not 100%. I think it's up to 95%. It also does decrease your risk of breast cancer too, ultimately, because of the hormonal changes. But it's not, without its own risks and side effects. So when we get into a discussion about where she is with her childbearing and her family status, her desire for whether she's started her family or not, if she wants to, how big she wants her family. Because without your ovaries, she cannot have her own biologic children. That's a big discussion.
Yeah.
And then another discussion is in regards to menopause, because taking out your ovaries does put someone directly into surgical menopause, which can be mitigated now by great hormonal therapies that we can start someone on pretty quickly, basically before they leave the hospital, to try to decrease any menopausal symptoms. The stuff we give you exogenously is never going to be as great as what you're producing endogenously.
Yeah, our body does a great job at fixing things, and we don't do a great job replacing that with medicine. We really don't, unfortunately.
No. And another whole podcast about hormone replacement.
Yeah.
And all of the wacky stuff that's out there, but also all of the stuff that we're also not trained about on at all, even in OBGYN, about how to best replace hormones. But yeah, the specific thing I do talk about my BRCA1 patients about, because at our academic center, we do have this trial open, is doing a risk-reducing salpingectomy first. There's been plenty of publications, I think, this year and last about opportunistic salpingectomy, both, at the time of C-section, during, and other surgeries. But there is ongoing trials right now for high-risk ovarian cancer patients, because we don't know if taking out the tubes will actually lead to the same decrease in ovarian cancer risk. And we do have one of those trials open. And so I say that if you are interested in this, just taking out your fallopian tubes and doing a bilateral salpingectomy is a smaller surgery. You get the benefit of decreased ovarian cancer risk, probably up to 70% is what the data is out there right now. But to be safe, you should be in one of these trials so that we can monitor you better.
I mean, I think it is a very interesting thought. I mean, in the fact that we do put these women into menopause early when we do these risk-reducing surgeries. And that's, aside from childbearing, obviously, right, which is the thing that you cannot do without your ovaries, although they can take eggs out. So, like you said, this is a huge discussion with these patients, depending on where they're at with childbearing, where they're at, in regards to menopause, and how that ultimately affects them, because menopause also has a huge impact on life and lifespan. Not as big as when you get cancer in your ovaries when you're 40, but that we also know that taking out ovaries does reduce your lifespan if you don't give hormone replacement. And so there is a concern, and all the symptomatic things that kind of come along with it: loss of libido, difficulty with intercourse, hot flushes, problems sleeping, weight gain, all those things that come along with losing your ovaries. It's a hard thing to face when you're talking about taking out your ovaries. And so especially with BRCA, we do generally recommend that the ovaries come out because of the ultimate high risk of ovarian cancer, that these ovaries come out before they go into natural menopause. And this thought that you could maybe reduce their risk quite significantly, or maybe even significantly enough, which this is the research part, right, that we're trying to figure out, by just taking out their tubes, leaving their ovaries and leaving their hormones until a later date when you can take out the ovaries. Since we do think that most of these cancers that we've always called ovarian cancer may actually be tubal cancers, especially in the setting of BRCA 1 and 2. So it's a very interesting thought. And I think we all look forward to looking at what that data is going to be and what the actual, full risk reduction is. And if that is significant enough or enough to delay oophorectomy.
And then I think for BRCA1 specifically, I do also talk about hysterectomy as well, because there's that slight increased risk of serous uterine cancers. And it does make our hormone replacement modalities a little easier afterwards, where you might not have to do as much progesterone, or if any, after replacement or after surgery. And I think for our generalist friends out there who do end up doing these surgeries, to make sure that you are taking, you're doing the risk reducing surgery by the books when you're taking out those ovaries. So taking those at least 2 centimeters of the IP or the ovarian ligament, so that you don't leave any remnant of an ovary in there. If you have your ligature open, that's like 1.5 centimeters, I think is what I measured it to be. So a little bit more than that. Yeah. But it has to be open. I think the tip is a little under 1 centimeter. I do have to measure it again, but you can measure that before you do your surgery. And then to write on your pathology report for your pathologist that they need to do that CFIM protocol, SEEFIM, where they're serially sectioning and evaluating the fimbriated end, which with that tubal hypothesis of ovarian cancer is where where they can find those intraepithelial lesions, so the stick lesions. And then to send those patients to us.
Exactly. And then always don't forget to do washings, which is like doing those washings.
Wash everyone.
Which wash all the time. You can't be wrong doing those washings.
Yeah. You'll never regret. I can't say you'll never regret those atypical mesothelial findings.
Good mesothelial cells.
You'll rarely regret doing pelvic
Trying
washings.
To get more referrals, huh?
But yeah, so for this, I mean, just the start of the conversation, I feel like this isn't an hour if she's had no other counseling before. Because then we're not even talking about breast cancer, which I would say you should talk to a breast oncologist about what you should be screening. But you definitely should start screening by 35. I think starting at 25, you're supposed to start your breast MRI screening. And then to send them to a breast surgeon to talk about prophylactic mastectomy. And then to talk about what we can do for prevention. I think it's not just risk reduction, but we do have some data for preventing ovarian cancer, right?
We do. And I think for women who are younger, right, who are not ready for their oophorectomy, who are still waiting childbearing, or who are under the age of 35 or under the age of 40 with BRCA, or sometimes even under 45 or 50 with some of the other lower risk mutations. But, there are methods that are actually recommended in NCCN for risk reduction in those populations in terms of usually giving OCPs is the most common thing that's recommended. And I think even the Mirena IUD now has been shown to reduce the risk of developing ovarian or tubal cancer in the future. And so those are things that should be discussed with the patient. I find that most people don't want to do it just for risk reduction, but there are some people that do. And it is something that of course, I think you should go over with them. I think the other thing that we didn't necessarily get into is like at what, there's all kinds of patients that will come in that maybe don't necessarily have a mutation or that have maybe a lower risk mutation like PMS2, BRCA1, RAD51C. So there's kind of more rare, lower risk ovarian cancer mutations. And then there's people that might just come in with like a risk model that has a higher risk of ovarian cancer, but no actual mutation on the genetic diagnosis. And then, if that was the case, sometimes we still do recommend risk reducing surgeries. I think the threshold is about a 5% lifetime ovarian cancer risk for it being worthwhile to take out the ovaries. But of course, there's guidelines for ages for searching mutations, but there probably is no guidelines for patients that just have increased risk. But what are your thoughts on patients who have increased risk, no necessarily mutation? Is that somebody that you would offer a BSO to or a self-injectomy to?
I think that's where that art of medicine comes in, and like counseling that patient about the risks benefits of, it's still surgery, even though doing a BSO is relatively minor. Yeah, depending on what her risk profile is personally, like how she views risk. And I think importantly, talking to her about how ovarian cancer, unfortunately, we just don't have good screening. And that's the reason why we're doing surgery, or we would recommend surgery for someone with just a 5% risk, quote unquote, just, which is lower than like our lifetime breast cancer risk. But breast cancer, thankfully, has good screening modalities. Ovarian cancer, we've had now large population-based studies in multiple countries that show that, unfortunately, doing regular ultrasounds and getting that CA-125 doesn't change mortality. So we, at least at our medical center, and I think a lot of major medical centers, do not do that screening because it only ends up increasing interventions that are unnecessary. Reproductive aged women have cysts on their ovaries just from the fact that they're reproductive age and ovulating. So if they're not symptomatic, doing surgery or doing screening doesn't actually change anything. And once you do get ovarian cancer, the mortality and the outcomes are so much worse than if you were to, can't compare cancers.
Cross-cancer comparisons.
What we see with our ovarian cancer patients is that it's hard. It's hard. You can't catch it early as much as we've been trying and as much as we've been studying that. And we haven't figured out a good way to catch it early yet.
Unfortunately, like you're saying, different than breast cancer, patients don't get symptoms until they're at stage 3, stage 4. And so most of our diagnoses come in that stage. And it's just hard to cure. It's easy to get usually a remission out of that, but it's not lasting, and we all know it comes back, and we all know that it's gonna ultimately kill 95% of patients who develop these cancers. That's a huge percentage, and it's an incredibly morbid death from ovarian cancer. Not to say that it's not from other cancers, like you said, but it is just so much harder to find. And I think that's why our threshold, like we said, the 5%, that's why our threshold is so low for doing a risk-reducing surgery. And fortunately, unlike, a prophylactic mastectomy, at least, you have some small scars from it, but you don't have, it's not as huge a deal with like reconstruction and things like that. There are like we discussed, implications for menopause and other things with taking out the ovaries, but it's seems like an easier decision, I think, sometimes than maybe mastectomy.
Have you managed to do joint cases with breast?
I did one not that long ago. We did a self-injectomy, and they were doing a reconstruction for a patient who had already had breast cancer. But I think it really depends on the breast surgeon and how comfortable they are with that and what they're doing. There's been a couple that wanted, they were having tram flaps and they wanted to have it done with their tram flaps. But usually the plastic surgeons don't want to do that. They're afraid of contamination. So that's generally been my experience. I don't know. How about you?
Doesn't hurt to ask. I've had one plastic surgeon take me up on it. I was able to do a RSO when she was having her second or third thing for her reconstruction. But back where I did my residency, this happened a lot more. When people were getting like hysterectomies done. I mean, our BSOs are sterile, and it's not a clean contaminated procedure. It's a purely clean procedure. So it should not matter.
Yeah.
It shouldn't increase contamination. I can understand hysterectomy being a little bit of you're contaminating the field. But yeah, where I did residency, they were very willing to do joint cases. And so I think it really depends on the location, and just ask your person, the people around you.
Yeah, I think it's an important thing to ask. If I was a patient, I wouldn't want to go under more than one time if I didn't have to. I will say what I've done when I've had to do it like after the tram flap reconstruction, because they have that kind of like abdominoplasty scar, and then there's usually an incision around the belly button. Is I try to just keep all the scars in the prior scar. And I managed to do that with the prior ones, and I'm getting new scars, but it is still a whole nother procedure and a whole nother recovery process.
You're a little plastic surgeon on this side.
There we go.
Talking about the ultrasound and the CA-125, we do get it before surgery. So even if you're not screening for it, if you're about to do surgery for any reason, to do it just so you don't accidentally miss something.
No surprises.
Even if it's something like a cyst, that you can just be prepared that you're going in to be resecting or taking out.
I mean, probably if I was a general OBGYN and I saw a cyst or something that looked even a little bit concerning on somebody who had BRCA, I'd probably want to send that person to a GYN oncologist. Sure. Just so they have the option of staging if it was something concerning. And so I think for that reason too, it makes sense just to know what you're getting into and to make sure that you're not hitting any surprises when you enter. Nobody likes surprises in the OR.
No, not at all. So BRCA 1, we said 35 to 40. These these lower risk ones, we're saying about 50 is when we would recommend, or around the time of menopause, just to make hormone replacement, I think, easier and simpler. And then BRCA 2 is that other one that's a little different, where we're recommending surgery by 45. So not quite at 50, so not yet hitting menopause, but not as early as BRCA 1, just because it has a slightly lower lifetime risk of ovarian cancer.
I know some of the interesting data, I don't know if you've seen some of this on BRCA patients, is that they actually do tend to go through menopause a little bit earlier than patients that don't have BRCA. I don't have right on me the average age, but I think it is on average a little tiny bit sooner, which, you can mention. I don't know that helps a ton with counseling, but might make people feel a little bit better about doing things before the age of 50, 51.
And then for those patients who do have breast cancer already, which I think is more of the patients I see, at least in Lincoln, are already, unfortunately, have diagnoses, and they're getting their genetic mutation diagnosed after the fact of their breast cancer. This hormone replacement and risk-reducing surgery conversation becomes a little bit more nuanced. And I feel like the medical oncologists who are treating our patients all have very different risk thresholds for when they would be comfortable with patient being on hormone replacement. Even though I think BRCA, at least BRCA 1, most of those patients are triple negative, but triple negative can mean many different things in regards to percentages. And I've had med oncs who are highly against any hormone replacement afterwards. And some who say, if after 2 years or after 5 years, it'll be okay if their breast cancer is in remission for the patients who have very early stage. Yeah, I wish there was something published out there saying that it's okay or it's not okay, and which patients can or can't get hormone replacement.
Oh, yeah.
But at this point, it's a back and forth, I think, between me, the patient, and then their oncologist.
I feel like the standard answer is going to be no hormones in breast cancer. I feel like that's just, unfortunately, the standard answer. And I think it also changes my preoperative counseling because of that. A patient who's had breast cancer versus a patient who hasn't, in regards to taking out the uterus with the ovaries and the tubes or not. I feel like, for my patients who have BRCA2, you're probably never going to be able to give them hormone replacement. And if they have had breast cancer in addition, whereas if they haven't had breast cancer, then you generally would once you take out their ovaries, that is definitely an option for them. And so because a patient with BRCA2 can get hormone replacement if they haven't had cancer, I would be more inclined to recommend hysterectomy so that they could get their hormone replacement with just estrogen and not progesterone, which we know has an increased risk of for breast cancer.
And not for that uterine cancer risk
Right.
reduction.
Yeah, it's not for uterine cancer. It's just to help them take hormones more safely, Whereas if they have had breast cancer and they're BRCA2 and they're likely to be hormone receptor positive, I generally am like, let's just take your tubes and ovaries and keep it simple. Because if there's not an increased risk of uterine cancer, if there's not a benefit in terms of helping you take hormones safely, then there's not a huge benefit to doing the rest of the hysterectomy unless there is an actual uterine indication like bleeding or fibroids or something like that. And so that's usually how I would counsel those patients. So it really, the hormones have to be discussed a little bit before. And of course, you can never guarantee that somebody's always a candidate for HRT afterwards. Like, let's say they get a PE or a DVT or something happens that makes it harder to give them hormones, or they have reactions to it, or they, some people will get nausea, or some people will have mood changes that are unacceptable to them. So it's always hard to say that they definitely will be able to get hormones even after you do these kind of surgeries. The discussion of hormones when somebody has had breast cancer and how there's, like you said, no guidelines necessarily. And in general, the guideline is just no. But like you said, there are some oncologists who are more willing to entertain that idea. And one of the things that a breast surgeon that I used to work with when I was in residency always told us was that, it's a discussion with the patient depending on how severe the menopause symptoms are and what the risk is in regards to their breast cancer and the recurrence of their breast cancer in the future. So for example, in a patient who has had a bilateral mastectomy and has literally no breast tissue, what is the risk of that, of a breast cancer recurrence in that patient? Or if they never had breast cancer and they had a mastectomy for BRCA, what is their overall risk? So I think it is always a conversation, of course, with the patient and to some degree what level of symptoms they're having and what the absolute risk is for them and what is their risk tolerance also. Because there are some people that are like, I'm not worried about this cancer. I'd much rather treat my hot flushes, And then there's patients who are like, cancer is the most terrifying thing ever, and I never want to go through that ever again, and I don't want to take any risk whatsoever of that. And so I think, you have to individualize based on your patient's risk tolerance and based on what they actually find to be the worst thing for them.
Yeah, our patients' diseases don't read the book, unfortunately.
And patients have very different opinions on the things that they want and the things that are important to them.
And I feel like my own idea, like what would happen what would I choose and what would I counsel my family members on, that changes almost on the daily, depending on what's going on in the world even. Will hormone replacement be something that's going to be easy to get or hard to get in certain areas? But for the non-hormonal, there are, thankfully now, non-hormonal options that our generalist colleagues probably know better than honestly we do, or probably have used more. But there's, the typical paroxetine stuff that we've learned from med school and residency. You can do any of the SNRIs and SSRIs off-label. And then the new, what are they, NK inhibitors?
NK inhibitors, yeah. I didn't realize there's two, but there's two now.
Okay.
Yeah.
I've only used that one that I cannot pronounce.
The phenazolatant. Let me I sound it out syllable by syllable.
Yes, that one. What's the other one?
It's the NK3 and the NK1. This one is like a dual NK inhibitor. So I don't know if there's any comparisons. Okay, it sounds very similar. It's elezonitant. Wait, let me verify.
Okay.
Elenzonitant.
They're both natants.
Zenitants.
Okay. Yeah, I feel like that has worked really well for patients who have mostly vasomotor symptoms as their primary menopausal symptom. And insurance has been pretty good about covering it, from what I found. You do have to do a little bit more monitoring in the beginning for their liver enzymes, but I was pleasantly surprised. I think I was a skeptical about this new mechanism, but it's tended to work well for my patients at least. What do you think?
I think it works pretty well. Then the patients who I've tried it in, they've been very satisfied, especially in the ones who have tried the alternatives like paroxetine or gabapentin. Most people try that and that kind of helps a little, but I still feel hot flushes all the time. I see some insurances cover it really well. Sometimes I've had a lot of insurances say that you have to try other alternatives first, and if you try them and fail them, then you can get a hold of the Veoza, or the fenazolitant. But it is kind of interesting because apparently, and I went to when this drug first came out, I was I was really interested because of all the situations in which we can't give hormones, and then we have menopausal patients. But apparently, it works in the same way. It works on the same neuron that estrogen binds to. So it has like an alternative binding site for the NK, and there are actual neurons that like propagate the hot flushes, and they have some data that shows that these neurons either grow or like propagate after menopause when you don't have the estrogen stimulation. And so it's like an alternate receptor on the same neuron, and it just seems to make a lot of sense why it would work. So I thought that the mechanism was kind of cool. But like you said, there is some data that in a very rare instances that the fenazolitant can cause hepatic impairment. And so their recommendations for monitoring have increased to, I think, monthly monitoring of LFTs, and then like every few months for the first year or so of use. And so I think that may tend to scare some patients away when you tell them that we have to check your liver once a month. I mean, I think it is really rare that anything happens. And I really think there really have been a couple instances, and just those couple instances have made them concerned enough to put those warnings on the drug recommendations.
And then I do try to talk about lifestyle measures like exercise, sleep, hygiene. I tell people to try acupuncture if that's in their budget and where they're in an area where there are practitioners, since there are several systematic reviews and meta-analysis saying that acupuncture can decrease hot flashes. But I think the data is not as good as things like CBT and mindfulness, but it's still up there.
So when can I start sending my patients to you for their acupuncture?
We'll talk about that in future episodes. We'll get there. I'll come. I still don't have a good script to say when someone asks for what other options can I do, and are there things that I can take like supplements and whatnot. And I just ask them to be frank with me with what supplements they're taking, so that we can go over the ingredient list and make sure that there's nothing in there that's just basically estrogen if they're not.
There's a lot of stuff out there that's basically estrogen.
Yeah, which is why it works.
Yeah, you get worried when it's something that's over the counter that works. You're like, there's probably some estrogen in there. We've talked a lot about BRCA, breast cancer, ovarian cancer, risk mutations, but we haven't talked so much about Lynch syndrome, which is another big part of OBGYN and OBGYN cancers. Now that, of course, endometrial cancer is becoming the most prevalent, or is the most prevalent GYN cancer, I think it is important to mention that. So when you see patients, I guess, what is the way you would typically screen for Lynch syndrome? I mean, I think a lot of our patients come in with a diagnosis of endometrial cancer, and probably important for generalists and for our med oncs to know is like what testing we do on the endometrial cancer tissue, because a lot of our generalists will do endometrial biopsies and they'll get these results. And sometimes they can get started on a workup that would be helpful for the patient and helpful for us. So what do we usually ask for on that biopsy result or on the tissue that we get back that comes back with endometrial cancer?
Yeah, I think if you get a biopsy that shows endometrial cancer, now a lot of places are doing reflex testing to the MMR proteins, so the mismatch repair proteins. So you can ask if you don't see that, they usually have a little blurb at the end saying MMR proteins intact, or saying the entire thing, MLH1, MSH2, MSH6, PMS2 genes are all present, or proteins are all present. Expression is all present. But if you don't see that, if you can ask your pathologist to send those, that will kind of get things rolling a lot better, because while it doesn't change our initial gold standard recommendation, which is a hysterectomy, it could change instances where someone gets referred for genetic counseling, or for those who potentially want fertility sparing surgery, it might change what we do or the options that there are. So it would just move things along faster. They do send it. Sometimes you end up getting, or they just say the MLH1 is lost, or MLH1 and PMS2 are lost rather, right? Those are the two that are linked. And correct me if I'm wrong.
No, that's correct.
Right. And then that's where you can, sometimes they reflex to this, but where you can then ask your pathologist to send for MLH1 promoter hypermethylation, which is an epigenetic way that MLH1 protein gets unexpressed. And because those two, MLH1 and PMS2, are linked, it then leads to loss of the PMS2 protein as well. Most of our cancers, endometrial cancers, who end up showing some type of MMR loss is from hypermethylation as opposed to actual germline mutation. But if they say any of those other ones are lost, then can be somatic, so it can just be lost in the uterus or in the endometrium itself, but can also mean a germline mutation. And I think that's where family history and personal history comes into play. We've heard about the Amsterdam criteria, which I cannot list for you right now, but family history of multiple people with different types of GI cancers, as well as endometrial cancers. I think also age comes into play for that as well. But when I hear someone who's had multiple endometrial cancers or someone who's had GI cancers, whether it's stomach or colon and uterine cancers, or ovary cancer, like when all of those things come into play, the Lynch bells really start to ring.
Yeah, we forget sometimes that Lynch is also an ovarian cancer mutation or an ovarian cancer syndrome, and that BSO for Lynch syndrome is also part of the indication. So if you do have somebody who comes along and you're planning on doing hysterectomy for benign GYN indications too, and you hear their family history and you hear, oh yeah, like grandma had stomach cancer and, mom had colon cancer at 45 and my brother had colon cancer and my sister had uterine cancer, then probably you want to get genetic testing to see if the ovaries need to come out if you weren't already planning on doing that before you do your surgery. Because you don't want to miss that opportunity if you're already going in there and doing surgery. And then maybe you want to do an endometrial biopsy if you knew they had Lynch syndrome before you go ahead and take them to surgery. So I think not missing out on those kind of key details when you're planning kind of just helps make sure that you're not missing things in the long run. And then, like you said, if you have somebody who has had a diagnosis of cancer, the tissue can be tested as an initial screen with immunohistochemistry to see if they're missing any of those mismatch repair proteins. And then from there, specifically if it's MLH1 PMS2, you can send them methylation testing because it can just be a change within the tumor. And then, of course, because any of those missed proteins could be an individual mutation in the tumor versus actually in the germline and in all the cells of the body, then, of course, if anything's positive, that's a way to know who to send to genetic counselors and who to send for genetic testing. I think even if mismatch repair proteins are intact, we will send young people anyway, just because, why did this happen so young? Although endometrial cancer usually
under 40. Right?
Yeah. Like, why did this 30-year-old get endometrial cancer? Especially if they're thin habitus, getting regular periods. You're like, why did this? That would be a very weird thing to happen. And like you said, anybody who, even if they're methylation positive or their mismatch repair intact, but if they have a very suggestive family history, we're still supposed to send them for genetic testing because there can be reversion mutations or they can be a gain of function that comes back. Be very unusual, but it is something that can happen. And I think, what the genetic counselors get really into the weeds with even sending RNA testing and all kinds of things for specific ways in which these things can be missed or altered in some other way too. So there's all kinds of some crazy stuff they do to kind of diagnose these patients. Probably not crazy. It's not crazy. But, for me, I'm wow, okay.
Yeah.
I didn't know you could do that.
Lynch is also, right, it's not just one thing. Lynch is the risks for Lynch, it's like a family of these repair mutations. Some of them are the common ones, MLH1, MSH2, but the other ones, they also have different risks for endometrial ovarian. Like PMS2 doesn't really even have an ovarian cancer risk, really, versus all of the other stuff like bladder, brain, other organs that are different in
screening,
percentage.
to get a yearly urinalysis for patients with Lynch syndrome and a yearly or biannual colonoscopy and some endoscopy and it kind of just depends on. Sometimes they look at the actual family history in addition to the actual mutation to determine what screening they need to do. So it's pretty variable depending on, like you said, your mutation and your family history.
Do you do screening endometrial biopsies for your Lynch patients?
That is a controversial thing. So it's a good thing to bring up. I discuss it with them. I think it used to be recommended, and now they're finding that it doesn't have a huge proven benefit. And so I tell them, hey, look, this is something that we can do. We don't have to do it. And the reason why is because endometrial cancer typically presents so obviously before it spreads. I do think Lynch-related endometrial cancers tend to be a little bit more aggressive than de novo ones that come from kind of just estrogen overstimulation. But, because people tend to present with symptomatic uterine bleeding, part of the education for somebody who has Lynch syndrome is educating them that if there's any changes in their period, changes in flow, changes in frequency, bleeding between periods, or of course, any postmenopausal bleeding, they need to come immediately for a biopsy and immediately to get checked. Some of them are like, it depends on how tortuous an endometrial biopsy is for you, right? I think for some people, it's not as bad. For some people, it is traumatizing. And so I have one person who really wants to do the biopsies, but they're traumatizing. And so she actually wants me to take her to the OR to do the biopsies. So, I mean, I think it's important to discuss with them, again, based on their risk tolerance and their need to have kind of some sense of control over predicting these things.
And there is, I think there's not really strong data, but some data that maybe a levonorgestrel IUD can have some risk reduction for patients, but there's been no randomized controlled trial. There's been nothing except retrospective stuff. So I do offer for patients to be on that. I mean, theoretically, birth control pills as well, similar type of suppression. I think your point about less so for doing routine endometrial biopsies, but with visits, just like seeing patients, right? Like for both endometrial, for Lynch, for BRCA, for a lot of these, when we're doing screening, we're saying without doing these procedures, we are just going to be doing exams and following patients with their symptoms, which is fine and dandy, I think, earlier on when you're doing annual visits. But like for BRCA, when patients are getting into their 30s, I do want us to see them every 6 months. And I've had cases where actually insurance wouldn't cover for them to get another visit in 6 months because they're only supposed to get one well woman exam a year. And so this other visit is not covered.
Interesting. So they actually have you bill as well woman exams for these like Lynn Cohen visits specifically for BRCA.
I don't bill it that way, but I think some of them get interpreted that way.
Interesting.
And maybe it's just me not knowing how to bill correctly.
Because nobody ever taught us.
I think, but you've had a case where even your risk reducing surgery was not covered, right?
Yeah, I did have a case. So that is actually a good thing to bring up for this podcast is that Medicare doesn't cover preventative care, which is insane to me. But I had a patient in her 60s who I think was BRCA2 positive, and we did a laparoscopic BSO for risk reduction. I actually kind of talk her into it because she kind of had the BRCA for a while, I think she had a VUS and they had upgraded it to a pathogenic mutation. And so, we went through this whole thing, planned her surgery, did her surgery, and then Medicare, after the fact, we found out that they don't cover it. And normally our hospital screens for their insurance and for the procedure that we're doing and make sure that the procedure is covered, with us as the physician and at the particular hospital that we're doing it before they even let the patient through the door for surgery. So I really don't know how this got by, but after the fact, Medicare was not covering it. So I think in the end, the hospital ended up just eating the cost of her surgery. But, I think it is an important consideration that they may need some kind of alternative or secondary insurance if they have Medicare only, at least for the time when you do that surgery. It's insane. Yeah.
Yeah. Importance of having a lot of people on your side when you're doing this. Who else do you refer patients to when you see?
Oh, yeah. So if these patients are concerned about their childbearing status, that is something that we kind of talked about, but we didn't get into. So, a lot of times you'll have patients who are under the age of 35 or who are 35 and who haven't had kids yet. And I think there's a lot of ways to go about that. But I think the best person to discuss some of these things with them and to discuss their options with them sometimes is an actual reproductive endocrinologist and infertility doctor, because they can talk to them about, what are the chances they're going to get eggs, or do they need to have assisted reproduction, or can they save their eggs and then have a surrogate later on, or save their eggs and if they're not going to have their uterus out, use their own uterus. So there's just so many permutations of what they can do for fertility if they're feeling the pressure of needing to take care of, their cancer risk, because say they're like over 35, they have BRCA1, they're really worried about ovarian cancer, they haven't had any kids yet, then that's definitely somebody who you'd want to send to an REI to either have egg retrieval or have embryos taken out. I always have a conversation with them that, hey, if they're say 25 and they get diagnosed with BRCA, that one, you may go into menopause a little early, like which I kind of touched on briefly due to the BRCA. Two, there is a recommendation to take out your ovaries at 35 to 40 when you have BRCA1, 40 to 45 with BRCA2. And you might want to start thinking about reproduction and having kids as soon as you feel ready or able to do that, which unfortunately might make people feel rushed into that. But that's another point at which you might want to say, hey, there's another option to store your eggs if you don't have a partner, or to store embryos if you guys are not ready or not sure you want to have kids. And then I think, beyond that, I can give them a little bit of advice about how that works. But I think it is important for them to see REI and to see what the options are.
Yeah, I completely agree. And at Lincoln, we luckily have a REI who actually comes to our meetings most of the times, which is fantastic. And she can throw in a lot of like really important, like new things, new great things that they're doing in the field of fertility space.
No, I'm hoping that eventually we get to start saving actual ovarian tissue, That'd
be so cool.
Because I think there is potentially a lot of benefit to that beyond just egg retrieval, and you're taking the ovaries out anyway. Like, let's just keep it.
Yeah, I was saying for the early patients or the young patients, you mentioned cascade testing earlier, is that if someone has a genetic mutation, you should recommend that their family members get tested as well. And for children, that can be, they can be young. And that conversation about when do I test my kids should be up to the kids, usually. I think for like BRCA and Lynch, you wait till they're 18 or older, unless there's an index or a case of a really, really young breast or colon cancer or something.
I think it's kind of up to the parents too and how mature they think their kids are. And I think ultimately the recommendation is that you leave the choice up to your kids about when to get tested, like you said, unless there's something that happens really, really young and you need to know about it in advance. But, there's some kids who are mature enough to make those decisions, under the age of 18, if the parents condone it. So I think, and then if it's reasonable, right? If it's something that's going to make a difference at that point in time, or if it's just going to make them anxious.
Yeah, I think that was a lot. I feel like there's still so much on our list that we didn't chat about. You can talk for like another hour about this, but we won't do that.
We'll be open to questions later.
Yeah. We never get this chance to just kind of chat about things with everything that's going on with like clinic and education-wise, you're our fellowship director, so like figuring out how to teach this to our fellows and our residents.
These are topics that we bring up in our education day for our fellows. Like, so Lynch syndrome, what's the risk with PMS too? And these are the questions that we end up asking them. But yeah.
Well, thanks for chatting with me today.
Same.
And hopefully, we're going to do this again, right? In a couple of weeks, a month or two.
Yeah, I think our next topic is radiation. Is that the plan?
Yeah. And then following that up with screening for GYN cancer, or not screening, surveillance. GYN cancer surveillance and all the updates.
Sounds good.
Well, have a wonderful rest of your day.
Thank you. You too. Okay, that was fun.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrizio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
See you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.